You're listening to The Dental Guys, episode 55. I keep missing my blocks. Dentists deliver more local anesthetic than just about any other healthcare profession. Dental anesthetic is better today than it's ever been, but for some patients, it can be frustrating. Jon and Wes debunk some of the myths about local anesthetic technique and shed some light into what you can do to increase your success. We discuss some tips and products that may increase your success with the dreaded irreversible pulpitis. Hurry up and get numb. We've got teeth to cut this week on The Dental Guys.
This episode of The Dental Guys is brought to you by the Dental Crafters Network, your implant restorative connection. From surgical planning to patient-specific guides, quality implants, and final restorations, the Dental Crafters Network provides one relationship with infinite possibilities. Call 1-800-472-8302 today. That's 1-800-472-8302.
And welcome to this week's episode of The Dental Guys. I'm Wes, the Dental Guy.
And I'm John, the Dental Guy.
John, we're all listening to this episode right now, and are we sleeping from tryptophan because it's the
We're
week?
In a food
it's
coma.
Food coma.
Or as my daughter said one time, a food coma.
How many turkey days do you have in your family? I mean, like, we usually eat over a period of days.
Well, it used to be less, but we have a problem because now I have a specialist that sends me smoked turkey every year, whether I want it or not. I mean, I want it.
Is it already cooked?
Yes, it's fully cooked, smoked, and it arrives overnight from the place.
I'm switching specialists.
And
sorry.
But see,
you're
then
listening to this right now, and you're my specialist. Come on,
your
guys.
orthodontist is out, right?
Yeah.
Or out. We're done here.
I'm sick and tired of this.
Yeah. So my mom makes a giant turkey.
Oh man.
My in-laws don't really do that, but my mom does, and usually my wife will make a small one. But we've stopped. My wife stopped making them because we get this giant smoked turkey. It's huge.
Yeah, you can only eat so much, right?
Yeah, I mean, I love it.
I love turkey. I mean, I don't care whether it's white, dark, or whatever it is, fried,
yeah, bring it,
baked,
bring it,
whatever.
What's your favorite way to have it though?
Well, here's my favorite way to have it. So
Okay.
it's the day after Thanksgiving. Okay, you come in after a good morning of hunting deer. You've got up early. You've had some oatmeal, and because when you're going to get back around noonish. Okay, and hopefully you've got a big haul. You've got a big deer in the back of your four-wheeler, and you crushed it. But what you're really looking forward to is getting out the turkey, the half that had not been trimmed yet. Okay?
Okay.
Because there's that half. And you slice off a most succulent piece of white meat.
Okay.
It's about 5 millimeters thick, 5, no more.
Okay. Okay.
And you need a couple pieces like that. Okay. And you take and you toast some good white sourdough bread.
Okay.
You slather on some really high quality Duke's mayonnaise. Okay. A little bit of Dijon mustard. Okay.
Okay.
A little bit of salt, a little bit of pepper, and some fresh iceberg lettuce. Okay.
Okay.
And then you take homemade dill pickles. Okay.
Wow.
And you slice those.
Really good.
And you layer it on there. Now, John, you and I eat very similar things, and we're not afraid.
Yeah.
So I know that your mouth's watering right now because mine.
Oh yeah,
is.
I'm liking.
So you
what you're
lay
saying
those
right now.
turkey slices on there, and if they drape over the edges, no big deal. Okay. And then you've toasted your bread, so you've got that crunch. You've got the crunch of the outer side. You've got the crunch of that iceberg lettuce, and you taste the Dijon, and then you've got the spike of the dill pickle because that's got a little bit of kick to it. If you want to take it to the next level, you get some really high quality kettle cooked potato chips.
Oh, I know. Yeah, I know where you're going with this.
And you layer it in with
if you want a crunch.
Crunchy crunch. Okay?
I mean, this is... I had no idea. This was like I just unleashed the beast, man.
Stop.
Who knew that you had this like concoction? You're just like waiting for someone to ask this question. We didn't even talk about this before the show.
Man.
Jeez. All right. So what else do you have to do? I can tell there's more. But wait, there's more.
It's always a little nip in the air outside. Okay?
Yes, that's true.
So you've got a fresh brewed pour over on hand. And you know those leftover desserts? We're not going anything like crazy here. We're going with the apple spice cake. Okay?
Oh, of course, yeah.
That the mother-in-law makes with just a little slather of drizzle on top of that. Like a little, like that sugary syrup stuff. And it just like glazed over top. And as you cut through it with your fork and you take a sip of your coffee.
Okay, dude, this is like food porn we're going here.
Man, I tell you what. There's nothing like coming home with a big deer on your four-wheeler and then looking forward to tearing into one of those sandwiches.
So that sandwich. Well, this year we're doing the Turkey Trot 5K.
Nice.
In the morning. Instead of the deer, we're doing so that way we feel slightly better about gorging ourselves. This is your Black Friday? Yeah, this is this Thanksgiving morning.
Oh man. Oh no,
Thanksgiving morning.
So
you feel a little better about eating all that stuff, all that good stuff. Now you want to talk about specialists giving you cool stuff though.
I don't even want to hear it. I need a
Let me tell you what the coolest specialist gift that I have ever received is this year. I was the announcement just came and they actually sent it as
I'm really a little upset about it.
I know you are, and that's why I'm telling it. So and they sent it. It was so beautiful. They sent it. I didn't show you the card, but they sent an email card, and it looks like the words are coming down the screen. And what it is, they have rented out the best theater in our area, and of this big theater, they've rented out the high quality one with the high quality sound, high quality screen, and everything. And they've rented out the entire theater for a 9:30 a.m. showing the day after Star Wars opens. So it's going to be like a showing that normally they don't even have, 9:30 in the morning. I'm rolling in there, and only their referring docs and their teams and their family can go and see Star Wars.
And what's going to happen
16th.
later on that afternoon?
Later that afternoon, I'm going to see it with you.
You're a scoundrel. You're a scoundrel, as I quote Princess Leia.
That's right. You're
a scoundrel. Yes. If I was Guido or whatever, what is not Guido?
Greedo.
Greedo.
Yeah. Guido. It's like the Godfather version. But I'm gonna be able to see, and so and he's doing that.
I don't want any smiles. I don't want any thumbs up.
I'm not. Yeah. No, listen, when I see you later that day,
you're going to have a muted face. A muted face.
Yeah, you're going to walk in. You. No, what I'm going to do is I'm just going to shake my head like it sucks, man.
No, I don't want any of that.
I'm just going to be like, it's... No, I'm not going to... But I mean, I will definitely not play it up. If it was really good...
with my Jedi hood on so that I can't see you.
Yeah. If it was really good, I'm not going to say anything. If it's really bad, I'm not going to say anything. If you ask me, I'm just going to be like, I don't know, man. I don't remember anything.
Hey, listen.
So... Anyway, so it's going to be a pretty awesome...
That's pretty awesome that your specialist
end of the year for both of us, it sounds like. Between your turkey sandwich and Star Wars, experience. Dude, we have everything we need.
Let me tell you. Let me tell you what.
What do you have going on there? It looks like if you're watching the video version of this, Wes appears to be holding a 27 long needle.
What is this show?
So it sounds like that means this show might have something to do with that.
Let's get this party started.
Let's get it going, man. Because this is really where we spend, how many times a day do we spend uncorking that needle and going to town? And we have all these people who are so confused about how do I get patients numb? He's uncapping it. Nice. I heard that sound. It's like popping the cork, man. But I mean, what we want to talk about this show is what's the deal with anesthesia? Why is it so hard?
What elixir are you using?
Yeah, man. What should we be doing to get our patients numb? How
Oh
can we
my
get better at
goodness.
that? There's a lot of controversy about that. And as you guys know, the Dental Guys is all about taking some of the everyday things you guys do and we all do and trying to back up what we do with research and find out how we can get better at it. So I think probably the thing that we want to go through first is let's just talk about how Wes and I get people numb. Like, what do we do? And then we're going to break it down a little bit into why we do what we do and some things we've learned from some smarter people than us, and then tackle some of the controversies. And at the end, we'll give you some products that you can use that can make an immediate difference in how you get your patients numb. So let's just dive right into it, Wes. Let's just start with this. Let's start with upper teeth, because upper teeth are the teeth that for most of us, we have fewer problems with. And of course, that's because in the maxilla, it's a lot more forgiving. The bone's a lot more porous. It's a lot easier to get anesthetic.
Mm-hmm.
So what are you typically doing for, say, an upper anterior tooth to do restorative treatment? And what are you doing for a posterior maxillary molar, say at number 3 or number 14, if you're doing restorative treatment? And then what are you doing if you're doing surgery? How is that changing? Let's go through your technique a little bit about how you get a patient numb.
So I always start out, let's say we're doing restorative on 6 through 11.
Mm-hmm.
And I guess really this doesn't change for me from a restorative standpoint, really for the entire maxilla as far as restorative treatment goes, and really even maybe most endodontics, let's say that for the maxilla. Okay, surgery might be a little bit different. We can get into that. So I always start all of my anesthetic with a topical anesthetic, and stay tuned because we're going to reveal what one of our favorite topicals that could change your practice a little bit. And stay tuned for that because it is our product of the week. But we start out with a topical anesthetic. I do dry the tissue, which I think is key, with a 2x2 gauze. So I wipe with my gauze, and my topical goes in there for about 15 to 30 seconds. And you're thinking, man, what topical is Wes using? Because John's using the same one and we didn't even know it. Okay. And so it's funny, but we do use the same things occasionally. And then I immediately start with a carpule of Citinest, which is prilocaine, and slowly dispense a little bit of Citinest. And here's the thing about my anesthetic technique, because my follow-up injection is articaine after I've dispensed a little bit of Citinest or prilocaine. Because of that, I only insert the bevel to, just past the edge of the bevel. I'm not putting deep anesthesia in for restorative, meaning I'm not going in more than maybe 1 to 2 millimeters past the bevel. And so it's a very, very controlled, very slow motion. And then articaine goes in right after that. You might say, well, why are you putting Citinest or prilocaine in first? Well, because it's very kind to the tissue. It's more pH balanced. You get less of that anesthetic burn. And I do use 30 gauge needles in the maxilla most of the time. And I'm really just doing buccal infiltration, facial infiltrations for all of my restorative, and just putting the anesthetic right next to the vestibule and letting it diffuse through the bone. Because articaine is so lipophilic, meaning it loves fat, and the maxilla is full of medullary bone. It will diffuse very, very good. It'll diffuse a lot better than lidocaine. Some of you guys that have been to some of my courses on implant dentistry are surprised about how very little anesthetic I use for implant therapy. Part of that has to do with knowing your anatomy, and part of it has to know with, and that's pretty much it, and just knowing how to put it and where to put it. But for restorative dentistry, John, I'm using prilocaine followed up with a carpule of septicaine. I don't always use a full carpule, but most of the time that's my protocol. What about yours?
Yes, it's I don't use Citinest.
Mm-hmm.
but I pretty much am getting topical on there. I'm leaving it on there maybe a little longer.
Mm-hmm.
Not necessarily because maybe I don't need to be leaving it on there as long, but leaving it on there a little longer. And typically, after I've put it in, I'm kind of talking to the patient a little bit. I've got like a canned thing I usually say about post-op. I'm already talking about that while I'm waiting for my topical to work,
Mm-hmm.
um, and then I'm using just Articaine pretty much on all maxillary teeth, injecting slowly. Again, like you say, not using a lot. I don't think you really need to use a lot for restorative treatment in the maxilla in almost all cases. The only difference that I will make in the posterior maxilla is I'll typically do on my second molars, my first molars, I'll do a posterior superior alveolar injection as well if I'm doing endodontic treatment. So that's the only real difference is I'll go, up and back if I'm doing that. But for, Articaine just works so well, and it doesn't.
Mm-hmm.
You don't really need anything else. And talking about that in the mandible, we'll kind of get to that, but let's continue with the maxilla because, it's just so much more straightforward.
Right.
If you're doing surgery, let's say you're taking a tooth out.
Yeah, single tooth
And
extractions.
yeah. Tooth extraction, the maxilla, I don't change things very much with what I do. And the only difference is what we do on the course on the palatal side. And I think there's different ways you can go about that. And I do it differently with kids and adults. With adults, typically, because I know that there's a potential I might have to every now and again extend my incision or a flap or occasionally. From the beginning, I go ahead and block on the palate. I usually do a greater palatine or lesser palatine or incisive or those types of things because I'd rather have more regional anesthesia in the palate. But sometimes not. If I'm really confident that I'm not, if it's a periodontally involved tooth or something, I'll just go right to the area. And a lot of times with kids and with some adults, I'll sort of just walk it around. I'll blanch the papillary tissues with anesthetic. I'll watch that blanching kind of work its way around to the palate, and I'll kind of follow it around. It takes a while. Sometimes, you have to take sometimes 30 seconds, a minute. You maybe have to give 2 or 3 different kind of small injections as you walk it around, but you can truly give a pretty painless palatal injection if you work your way from the facial rather than just going right to the palate. So for kids, I'll usually do that if I'm taking a tooth out. If it's an adult, depends on the adult, depends on how extreme I think the surgery is going to be. A lot of times I'll just do a block right from the beginning. But using the same anesthetic, just using good old Articaine. What about you for surgery there on the upper jaw?
For surgical, I rarely give a greater palatine unless I'm doing full arch treatment.
Mm-hmm.
If I'm doing an extraction of number 2 through a single tooth extraction, anywhere from 2 all the way up through the anterior, I typically do what we call 4-point injection. And I'll start after my infiltration has set there for about 5 minutes or so. I'll come back in and take a 30 gauge and basically take and inject into the PDL, mesial buccal, distal buccal. And as I'm injecting, I'm really pushing hard, and you'll begin to see, and they'll start to feel out to patients, like I'll just kind of talk them through that. I'm like, you're going to feel me some pressure here. And I'll apply that pressure, and you'll start to see the palate start to blanch a little bit from the epinephrine. And that kind of gives me the signal that some of that blood supply has been compromised on that palatal side, which tells me, hey, I've got some anesthetic over there, okay? Mm-hmm. Because what follows arteries, okay, and is nerves. And so I'll come and then I'll go mesial lingual with an injection. And whenever I do these injections into the PDL, think about a Ligajet and what it does, but take a 30 gauge and push it up into somebody's PDL as far and as hard as you can, and then you'll start to see the palate start to blanch.
Yeah.
And then you're talking to the patient, and I'm like, do you feel that? And they're like, maybe just, they're kind of like holding their finger up, and they're going like that, like a little bit, but it's not bad. And then maybe I'll come down onto the palatal side and inject locally right there with some articaine, but not until I've done my 4-point. Now that's my typical protocol for extractions. Now, full arch is totally different. Full arch is a situation where I'm doing, greater palatine block, and still doing some massage, depending on how the patient's sedated or not, depending on how that is, and depends on how aggressive and how fast I get through the anesthetic part. Now, I spend a lot, people come and see me and they tell me that no one has ever gave them a shot like that. And I don't do anything special. Now, Jon and I, we would be glad to show you in some form how we do this with video. And if you want to see that, you let us know in the comment section on Facebook when you see this released. Say, hey, I want to see you in live how you do this, and we will definitely do it. We'll hook the cameras up, and we'll record it, and we'll walk you through how we anesthetize someone in the maxilla or the mandible. Let's go to the mandible, Jon.
Yeah.
What are you doing?
Yeah, I think that, the mandible for some is kind of the nemesis, and we're going to work our way back from the easier teeth to the harder teeth. I think a good place to start on the mandible, just to kind of mention, is for pediatrics. I think that we both stopped using blocks when articaine became a thing. I mean, there's really no need to block kids at all, I find, even for extractions in the mandible. With articaine, it's just so good, and kids' bone is just so medullary and porous that you can really get away with just about anything with articaine infiltration on the buccal, and it also doesn't give them that residual tongue anesthesia, which sometimes we get with the lingual, of course. So pretty much for kids, I think Wes and I both, we're just using articaine infiltrations. Works great, has eliminated a lot of issues. If you're still blocking kids, man, stop that. Just don't do that anymore. You don't need it. You'll be amazed at how well articaine works in kids. But getting to adults, I even find on a lot of anterior teeth with adults, I'm not having to block if I'm doing restorative treatment. If I'm using articaine, I can get away oftentimes with mandibular incisors with just articaine infiltrations. And so it's really changed the game, I think, over the last 10 years in dentistry with how articaine's, what it can do. Now, as we work our way back, this is where we start to get to the area that for most dentists is the most difficult and the most controversial. And that is the mandibular block, the inferior nerve block. And I think let's start off by just saying, what do Wes and I do? And I think for both of us, it's basically the same with the exception of Wes using sit-nest. But we both use articaine for blocks, right, Wes? I mean, you're the same.
Yep.
I'm using articaine for most everything in my practice. There's really not a lot of exceptions. I made that transition a couple of years back, and
I don't have lidocaine in my practice.
Yeah, there's just really not a use for it anymore in dentistry like there used to be, and we'll get more into that later in the show. But I think the question really comes down to what are dentists struggling with, or what are the frustrations? Why are all of these things out there?
What's the hardest thing to numb, Jon? It's an abscess. It's an irreversible
it's an abscess
pulpitis.
Tooth, right? It's a lower molar. Just in general, lower molar pulpal anesthesia is the challenge. And rather than reinvent the wheel as we go through this, we really just are going to draw upon. And you guys know, if you listen to the show, we're big fans of what our friends there at the American Association of Endodontists do with the Colleagues for Excellence. We almost wish there were more of these out there. But back in 2009, almost 10 years ago, they put out a great paper which has not really, none of this stuff in this has really changed at all.
We'll link it on our website.
Yep, put it on the website. Very easy to find online too. You can Google it. But it just basically, the title of this is Taking the Pain Out of Restorative Dentistry and Endodontics, Current Thoughts and treatment options to help patients achieve profound anesthesia. And they focus on what we're going to focus on for the next little bit, which is the inferior nerve block. And one of the best things in this, because it really goes with how we tend to run our show, is they have a ton of common misunderstandings.
Yeah, let's myth bust some of this stuff.
Yeah,
John.
it's myths, man. Myth busting. That's right. Because these are the things that oftentimes you hear people say when they miss a block or they don't get anesthesia and the tooth hurts, and the excuses that some people will give. So first myth is that lip numbness indicates pulpal anesthesia. And come on, guys, we all learned in dental school, no matter when you went, that there's different nerve fibers involved in soft tissue anesthesia versus pulpal anesthesia. I still remember oral surgeons in clinic talking about the A delta fibers versus the C fibers, and it was like, whoa, man, that's a blast from the past. But we know that if you get anesthetic around that nerve bundle, that the soft tissue is the first thing to get numb. It's the easiest thing to get numb, but the pulp is different. So they cite a number of studies, 12 studies they cite, that have found that lip numbness means the lip is numb, yes, but it does not guarantee pulpal anesthesia. And what they say is failure to achieve lip numbness occurs about 5% of the time with experienced clinicians. So that's interesting that if you get lip numbness, it does mean that the block was accurate enough to anesthetize the nerve fibers to supply the lip. But even with experienced clinicians, you may miss a block 5% of the time. So to me, that means that we probably miss our blocks about 5% of the time as far as getting it in the right location.
Right.
But lip numbness does not mean pulpal anesthesia.
Well, what about, John, if you stick the lip or stick soft tissue with like the perio probe or the Explorer?
Don't make that mistake.
Does that indicate okay, let's get started here, Sandy, and you start pecking on the tissue around the tooth?
Right.
Oh yeah, it feels great.
Yeah.
I don't feel
Can
a
you
thing.
feel that?
No,
Can you feel that? No, I don't
thing.
feel that. Well, you're poking the soft tissue. Didn't we just say?
Their lips
the
hanging
soft
down
tissue,
and there's drool coming out their cheek, and then you're like, oh yeah, you're dumb.
Right.
No.
And then you get the burr rolling, and you get in there, and they're jumping.
And they're like,
Right.
stop. So, soft tissue sticks can not and will not indicate pulpal anesthesia. What about?
I think too, this next one, lack of the myth is, well, you didn't get it in the right place. You didn't get it in the right place. And what they say is, I love it. They just say no.
Right.
Is they say the studies have shown that accurate needle location does not guarantee successful pulpal anesthesia. So even if you get profound lip anesthesia, it does not mean pulpal anesthesia there, but it doesn't mean you were not in the right spot.
That's right.
So yeah, every now and again, you're going to miss a block, but most of the time, the fact is we get our blocks. We actually get the anesthetic where it needs to be, but that does not mean that it's necessarily numb. And that goes right into the next one, which is
this is great.
That just because the lip is numb,
right,
it doesn't mean that the pulp is going to be immediately numb.
I like it.
Because how long does it take, Wes? How long do the studies show that it takes for the lip to get numb versus the actual pulp to get numb?
So this is crazy because everybody gets in a hurry all the time and they want to cut as soon as possible. Okay, so typically the onset of lip numbness is about 5 to 9 minutes. Okay, the onset of pulpal anesthesia usually occurs by 15 to 16 minutes.
Whoa.
So what we're saying is
that's a lot more than what most people think.
On a hot tooth, walk away, do a hygiene check, do a couple hygiene checks, do a night guard adjustment, and then come back. And you're like, oh, but I got to get done. And it's like, you got to wait on these hot teeth. I'm not saying you can't start, But
Right.
you're going to hurt the patient, and you're going to end up being frustrated and think that doing other things may get this patient numb. And whenever it's just really, you need to wait about 15 minutes, slow down, and wait.
Yep. And I think that's important, that, there are some things we'll get to that are some adjunctive techniques that can maybe get a patient numb quicker. And there's some good research to say that, the block is the thing that takes the longest, but
right.
you got to be aware that you're not just going to roll in there with 15 minutes and get it done.
What about this, John?
What do you got there, Wes? You got to.
I've got a little short needle that I broke, but we'll talk more about breaking and bending needles. You see that little black arrow on the needle right there, or on the hub of the needle?
What does that indicate?
Well, that indicates the bevel. And so there's a myth out there that says incorrect needle bevel orientation causes failure. So, I mean,
I've heard
you're
that.
doing a block, or you're doing an infiltration in the maxilla, which I never pay attention to the bevel of needle.
Well, and what this says is that there's a good study that showed that there was no difference in success of the block, no matter how you had the bevel oriented. So we need to stop saying that out there. If you're telling people that, if you think, oh, I just need to really pay attention to that, no, you don't.
I disrespect the bevel. Yeah.
Yeah, I think you should. Now, which teeth, if you hear people say, failure of pulpal anesthesia occurs more common, or it's the same in molars and incisor teeth. What do the studies say here, Wes?
Wow, lateral incisors are the biggest failure. 32% of lateral incisors experience lack of pulpal anesthesia.
Even with, it says 100% profound lip numbness.
Like we're talking like, what's going on here? You've blocked the mandible, and now the lateral incisors like hot, and it's like, huh?
Right. And I think that is a good.
It's twice that of molars.
It's twice as likely.
Yeah, 17% of first molars, and
I think that's where all of our discussion about articaine being better maybe in some of these situations with mandibular anterior teeth.
Here's the deal, John, is like everybody says that there has to be, and I'll have to say that I'm called out a little bit on this too, is that accessory innervation is the main reason for failure. Is that true or false?
Yeah, it's not true, man.
It's not true. It's not.
Because you hear this all the time. I mean, I heard this in dental school from a couple of faculty even. They said, oh, well, they're still feeling it because you got an accessory nerve.
Right.
Accessory nerve, or the most common is the mylohyoid nerve, right? You hear about that. Oh, well, the mylohyoid
30% of the time, the mylohyoid innervates the mesiolingual nerve of the first molar.
Right. Yep.
Well, here's the thing: is like I numb the mylohyoid for surgery, okay? Because we're doing surgery, so the mylohyoid gets numbed during surgery. But listen, for endo, I'm not numbing the mylohyoid, okay? I'm using articaine, okay? And we'll talk about what you can increase your numbness here just in a little bit as we go through some of these. What about this, John? Cross innervation causes the majority of failures in mandibular incisor teeth. So what we're saying here is that you're working on 24 and you numb, or you're working on working
on 24 and you block the left side. And people go, well, it's cross innervation. But then they studied it and they gave blocks on both sides, and there was no difference in the amount of missed air, or the number of teeth that still did not achieve pulpal anesthesia in the mandibular anterior. So we just have to realize this is a limitation.
It's not a major reason,
nerve
though,
block.
It's not a major reason.
You can nail the block and still not have pulpal anesthesia in the anterior.
Well, how about this one? Giving another inferior alveolar nerve block if the patient feels pain during operative procedures. Like, we just need to give another block. Does that really help?
No.
Not really.
If the patient has as they say right here, profound lip numbness. Now, if they don't have lip numbness, yeah,
Right, then
there's
we
a
got a
good
problem.
chance that
Right.
you need to hit them again. But if they have lip numbness and it hurts, giving another block, and I love what they say here is they say it probably is, if it works, it's probably that the first one was just finally starting to work. And you go, oh, yeah, it was the second block I gave. That's what did it. Well, no, probably you just should have waited longer because we know it takes 15 minutes to get pulpal anesthesia with a block. So if you're having this issue and you're blocking a second time, just again, if you look at the research, it's not the second block. It's just that first injection is catching up to you and your eagerness
John,
to
we've
get
all
going.
had these patients too that sit down in the chair and they're like, hey, the previous dentist, I just want you to know that he always had to give me more. He always had to give me more.
Yep.
And I love it when my assistant like looks at him and says, hey, you're in a great place because we don't really have to give more,
Yeah.
And they're like, really? And I'm like, yeah, just trust me. I was like, we got this. And they're like, I can't believe it. Like, seriously,
Right.
I love proving the patient wrong. It's like,
Yeah.
because there's this thought that 2 carpules are better than 1. John?
Yes.
It's not
Clearly
true.
been proven to be not true.
It's not true.
It doesn't. You could even increase the epinephrine concentration to 1 to 50, thinking that maybe you'll get better anesthesia. It didn't make any difference. So, the 2 carpules doesn't, and so don't waste your money.
Right.
Don't, if you're giving 2 carpules to everyone because you think 2 is better than 1,
Right.
no, you're wrong. Probably it's a time issue.
Hey, how about
I
these-
think in a lot of these, it's a time issue.
Yeah. How about this one, John? Well, I've really been trying to use Sitnest and mepivacaine for my patients that, have cardiovascular issues and they're high risk for palpitation, or that patient just requests no epi at all.
Uh-huh.
And I can't ever get those patients blocked. Is that true? Can
Yeah,
you block with mepivacaine and Sitnest as effective as lidocaine or articaine?
Absolutely.
You can.
There's no difference. Now,
There's
there's
no
a difference in longevity,
Yeah.
right? So
Yeah.
you'll have a longer time with the epinephrine containing anesthetics, but
Right.
studies have shown there's no difference. You can use Sitnest if that's all you wanted to use, or mepivacaine.
Mm-hmm.
You're still going to get a good, what the study says here is 50 to 55 minutes worth of efficacy from mepivacaine as an example, which is, pretty darn good. So
Right.
don't feel like you have to limit yourself. Oh, the patient says I can't use epi. Well, I can't block them.
Mm-hmm.
No, you're going to block them. And here's one of the others that I think is controversial.
Yeah.
People say, well, articaine is better than lidocaine for blocks. No, it's not. If you go back to the whole idea that 2 carpules weren't better than 1 carpule, well, all articaine is in terms of a block is just 4% versus 2%.
Right.
So yeah, even though it's a higher concentration, studies have shown articaine doesn't block better
That's right.
than lidocaine. Block better. Now again, for infiltrations,
Infiltration's
we know
different.
it's better.
Infiltration's more lipophilic, so that's why
Yeah.
John and I are using articaine in all cases versus
Yep.
lidocaine. We just chose to eliminate lidocaine from our office to simplify things.
Yeah, it just simplifies things. So I think we need to, let's move on to saying, okay, so if a patient, if you're worried about this, you go through all these myths, and it still doesn't answer the question of how do you move forward with patients if you are worried about whether or not your anesthesia is good. And they have, great suggestion in this article, which I use, I don't know, occasionally with patients that are really worried. You have a patient who comes in your office, man, last dentist who worked on me couldn't get me numb, kept going. It hurt all the time. They're terrified. A great thing to do is after you get lip sign and you feel you've waited enough time, but you want to be sure, it's a great idea to pulp test this with endo ice. So take some endo ice out, go right onto the tooth you're testing with the cotton pellet, and see if there's any response. If there's no response, you can feel pretty good about this, that they're not going to have an issue. Now, of course, if there's irreversible pulpitis, that's not always going to give you complete surety that the patient has complete pulpal anesthesia, but it at least is an indicator. And what the studies have shown is that people that have had previous difficulty getting numb they may experience more failures. It was interesting a couple years ago, Jada, there was an article in there talking about how redheads have more difficulty getting numb because there are some interesting studies.
My wife is
showing,
probably listening to this podcast, and she's a redhead. And let me just tell you right now, when Articaine came out, she was like, forget the lidocaine, give me the Articaine. And she's a testament to why I've really moved away from lidocaine, because if it works better on redheads, then it's got to be better for everybody else. And I can tell you right now, my wife has accessory nerve endings. It's proven that redheads do.
Yeah,
it's proven.
They're genetically predisposed to having lower pain thresholds and more difficulty getting numb, less sensitivity to these sedation solutions. And so there are people that have legitimate genetic family reasons or their own medical reasons for being more difficult to numb. So what do you do? What do you do if this patient, and one more thing they said, a slow injection,
60 seconds,
more successful than a fast injection. That's huge, because I think it's important that we don't speed up, slow down. So what do you do if a patient says, I'm difficult to numb, no one can ever numb me, blah, 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 and it's a tooth or it's an irreversible pulpitis situation? For me, what I do is we kind of joke about it. I call it I'm going to bomb the patient. I'm going to hit them with everything. That means I'm going to block them. I'm going to give adequate time, and I'm also going to do things that increase my success. And one of the things that that I think most people at this point know, although it was new just a few years ago, is an accessory infiltration. With Articaine, buccal infiltration increases the success rate of the inferior alveolar nerve block from 71% to 88%.
My goodness.
So that makes a huge difference in the success rate. And in patients, though, with irreversible pulpitis, it still was only 58% successful. So it's not for everybody, but still, throw everything at them. That means, for me, a buccal infiltration with Articaine, and also doing a PDL injection, like Wes mentioned. Doing a PDL injection is also not only a little quicker onset, but also is one more way, if you have a difficult patient, to try to give a little bit more just kind of surety to yourself that you've done everything you can before starting out.
You got a hot tooth, let me just tell you right now. You start doing the 4-point injection, and when I say, again, if you want to see this demonstrated, please leave a comment and we will demonstrate it. But I can tell you right now, just learning how to give a really good PDL with a 30 gauge, I like a 30 gauge, and really learning how to push that anesthetic down in that PDL. And you got to push hard. You got to really grip that harpoon like a beast, and really get that anesthetic down in there. And I really, really like doing that. And you'll get hot teeth numb faster, and the onset will be really, really good. The thing that's interesting about intraosseous injection is that it works as well. But I've eliminated intraosseous injections like the X-tip or is it Stabident?
Yeah, Stabident.
Where you drill a hole in the bone and deposit the anesthetic directly next to the tooth. I've eliminated that from my practice by doing Articaine buccal infiltration and Articaine PDL injections, and it just works. It just works.
So I think that what we should say as kind of a conclusion to this side of things is, if you are having these issues, first of all, go slower with your injections. Wait longer for your injections.
15 minutes.
Add Articaine to your armamentarium for infiltrations. Learn how to do a good PDL injection. And realize that in patients with irreversible pulpitis, you should pulp test these patients. You might want to pulp test any patient who gives you a warning.
It's a good tip.
Yeah, and then realize that in the irreversible pulpitis situation, you're not going to get 100% success. Sometimes without intrapulpal anesthesia, is sometimes you do everything you can do.
It's touch and go on these teeth sometimes.
That's right, and you sometimes have to do intrapulpal. So let's talk about one of the I think the interesting things is, you mentioned use a 30 gauge. let's talk about what is the difference. Why do we use a 30 gauge? And you also mentioned, with 30 gauge, you showed that needle earlier where you showed that it was broken. And that's an interesting topic is, what's up with this? We're always told, first of all, that, can you use a 30 gauge? That's the first question maybe we should talk a little bit about. Are you going to have problems with using a 30 gauge? And second is, what about bending needles? Is that dangerous? Wes, what did you find, first of all, on the bending thing? You did a little testing on that, right?
Yeah, so if you're watching on the video right now, and, as you're watching on the video, what you're seeing here is I said, why not see how many times it takes to bend a 30 gauge back and forth at the hub before it was broke. So I did three of each. I did a 30 gauge. You see it broke there like on the second time. And Here we go. That's 2. That's 3, 4, and then there's 5. That one broke it 5 times going back and forth. There's 1. You see I poked myself right there too, John.
Fortunately, that was sterile.
And then here's 3, and it's broke. So about 3 times for a 30 gauge, 4 times. And then here's a 27 gauge. There's 3, 4, and 5. And the 27 gauge broke at 5 every time when you're bending it at the hub. So I guess, guys, what I'm telling you right now is that if you're going to bend a needle, you don't want to bend it at the hub. In fact, one of the greatest guys to talk about, anesthetic is the guy that writes textbooks on anesthetic, Dr. Stanley Malamed from the University of USC, and he talks about bending needles and how the weakest point is at the hub. And so if you are going to bend a needle to maybe do a PDL injection, like in the posterior, don't bend it at the hub. And a lot of us, too, will bend a 27 if you're a right-handed dentist to give a right-handed block. You'll bend it at, like, say, a 30-degree angle at the hub so that you can actually kind of work your way around the mandible. It's more ergonomic, per se. And so what I would say about that, and I would say that Dr. Malamed says in his book, is that we should not be bending needles. And what I will say about 30 gauge, what I will say about 27 and 25 gauge is that they did a test, okay? And they dried the tissue and put the bevel of the needle just into the tissue with the 25, the 27, and the 30. Which one did the patient feel more? They couldn't discern.
I think
John.
they couldn't tell. Yeah,
there
were only
discern the difference.
I've only seen one study which indicated the 25 was a little bit more painful than the 27 and 30. The 27 and 30 seem to be equal no matter what study you read.
Right.
So that was interesting. Is that it didn't hurt as much as you thought, especially between 30 and 27. There's really not much of a difference, and yet for me, I'm using a 30. Pretty much all the time.
Are you 30? Are you blocking with 30s?
Absolutely.
Okay, so here's the interesting thing about blocking with 30s, because I block with 30s with sit nest, and I'll follow up with a long a lot of times, or just go right back with that 30. Here's the interesting thing.
So you have to hub it out, dude. That's the thing.
You got to hub it out, and here's what they found doing in an endodontic residency. I can't remember the actual paper, but I read it. It actually said that the success rate of blocks with a 30 gauge was equal to that of a 27 long when you hub it out.
When you hub it out.
Now,
and that's the thing
the issue with
here in your bending thing, you got to be aware that if you're going to hub it out and you're bending your needle, you're maybe flirting with a little disaster there.
Well, you have to be careful. One short broke with 2 bends. Okay.
Yeah.
Now, these are quality needles. These are Septaject. I use, a high quality Septaject syringe because I like the bevel on that. It kind of pierces the tissue in a way that I feel, I've just used them for years. I really prefer them. That's fine. You got your own needles, fine. Prefer your own needles, but you better not be bending them. Here's the thing, too, is that they found also that whenever you insert like a 30 gauge through soft tissue, the deeper that you go with a 30, the more deflection you get. The interesting thing about that study, though, John, is that the deflection evidently didn't cause missed blocks. And so even though there is some deflection with a 30 gauge as compared to a 27 in tissue buried, there was still no difference in blocking with a 30.
So I think we got to say that a 30 is fine to use and it works very well, but you have to be aware of the bending issue. If you're going to bend it, I think, at least bend it only once. Don't bend it multiple times. Be very careful bending it at the hub, and be aware if you're going to bend and then you're going to hub something out. Although it's rare, you could separate a needle and, you're kind of in trouble if that happens.
Yeah, retrieving that's very difficult.
Before we get to really, I think, a topic y'all want to hear about, which is articaine and paresthesias. I think everybody's kind of wondering when we're going to get to that.
Yeah.
I want to take a moment to talk a little bit about the Dental Crafters Network, because they have been, as we talked about, they have been doing some exciting things of integrating the whole system together, from planning all the way to implant placement, all the way to the restorative. But, let's focus on the implant side of that. Let's focus on the Argon K3 Pro system. And let's talk about some of the features that make that implant one of the implants that we really are excited about, and one of the implants that Wes and I place personally. And Wes, why don't you go through just quickly some of the reasons why you like the K3 system? Let's kind of summarize some of the key features. What has Argon been able to do? Because they've learned, if you've listened to the show before, they've learned from the history of implant design, and they've come up with an implant design that really takes some of the best things we know about implant design and puts them in practice. So tell us what you like about it.
Well, I think the thing that I like about it is the first thing is the surgical protocol. Now, we've talked about the studies about Lincovicus and him saying, hey, that tissue is the issue, maximize tissue thickness above our implant interfaces to protect the bone implant interface from bacterial infiltration. And so the surgical protocol for Argon K3 implants is driven to be placed subcrestal. And so that, to me, was like hallmark number one whenever you see a surgical protocol for an implant, that, hey, look, let's get it subcrestal, and it's meant to be placed subcrestal. And because of what they have is like kind of a reverse bevel, it takes the pressure off of the cortex. That implant has basically a bevel that reverses back to the platform, and that allows bone to grow up around the interface of the abutment implant connection. And John, I think that, you and I've kind of said that we think that connection may matter long term.
Yeah.
And short term, no one wants screws loosening.
Right.
And the type of connection that John and I have preferred is an internal, some type of conus internal connection that may provide better seal long term and less screw loosening.
Right.
And so K3 provides that. And these are just some of the things that we really like about it. I like the restorative flexibility. I mean, I could go on and on about this implant.
It's just overall a very well thought out implant. It's not the implant that, just was a design that somebody tried. It was a design that's been based upon years of our understanding of the science behind what works in implants and what doesn't work in implants. So if you're looking for the kind of implant that can really take your implant practice to the next level, I think take a look at what Argon can do for you, because I think that in the end, the reason we talk about products like this is because they work in our hands and they're backed up by all the principles that we know work in implant dentistry. So if you want to learn more about the K3 Pro, there are some resources. One of those is if you just go to argondentalusa.com, argondentalusa.com, you can learn all about them. You can also call them at 1-844-484-4998. That's 1-844-484-4998. That will get you directly in touch with a representative from Argon Dental USA. who can answer your questions, who can get you a catalog, who can tell you about the things that they offer. And of course, we know that this is all part of the Dental Crafters Network. So we're proud to have them be a sponsor on the show. So Wes, let's get to it, man. We know this topic, articaine and paresthesias, has been thrown around for a very long time with people saying, oh yeah, I don't use articaine because it causes paresthesias. We don't have a long time to talk about it, but I want you to really dig into this because this is your baby. You really have done a lot of research on this. So why don't we put this thing to bed, Wes?
Yeah, let's put it to bed.
Does articaine cause
really
paresthesia?
Sick and tired. No, it does not cause paresthesia. Okay, it does not. There is no scientific evidence to suggest that articaine causes paresthesia. You might think, hey, empirically it does. It does not. It does not. Listen, 92% of all paresthesias in the United States are mechanical lingual nerve paresthesia. That's the shock that the patient experiences. That's the profound anesthesia that they will, the paresthesia that they'll feel in their side of their tongue.
You're saying when you give the block and you physically harm
the nerve,
the lingual nerve,
that's right.
That is what's causing the paresthesias.
Yeah, that's what's causing
92% of the time.
Okay, so let's just run through this because
yeah,
it's a little bit of a rant for me because I see this on forums. I saw it about a year ago, and I just about flipped my lid again. And I even sent you stuff that day. I was like,
yeah,
I
remember.
Tired of this.
Yeah, I'm sick and tired of these kids.
We know the advantages of articaine, and it's unbelievable the advantages that it has. It has advantage. It's more lipid soluble, provides better mandibular infiltration. So what do we know? That already, just because you're going to give an infiltration in the mandible, it's going to increase your anesthetic, your anesthesia. We learned just recently 88% for molars. Okay?
Right.
So you need to be using articaine, okay? And you don't need to worry about blocking with it. So what is all this talk about? What is all this? Where does it come from? Okay, so 41% of all local anesthetics in the United States are articaine, okay, in dentistry. Guess how many in Germany? 97% in Germany.
Wow.
And guess how long they've been using articaine? Since the 70s. Okay, so they have the longest track record. In 1983, in Canada, there was a 21-year retrospective report of paresthesia. Okay? All right. It's been used
21 years.
21 years. So they've been using it since 83 in Canada.
Okay.
So this is the most cited, research, and it's terrible research. Let me tell you how terrible it is. Overall, local anesthetic paresthesia based on this retrospective report, 1 in 785,000. So, I mean, no matter what you're using, you're going to get some paresthesia, 1 in 785,000.
Okay.
2% and 3% local anesthetics, 1 in 1.2 million. Okay, with 4% solutions, 1 in 440,000.
Okay.
70% involved the lingual nerve. Now, here's why this study was no good. The duration was not documented. Greater than 30% of incidents, the local anesthetic was not identified.
Oh, that's good.
So they reported the paresthesia, but they didn't identify in 30% of the cases. The gauge of the needle was not documented. So if we know that most of them are mechanical, then we should know the gauge of the needle. The injection technique was not identified.
Okay.
It was all voluntary as far as a report, and the conclusions were very subjective. This is the most cited paper in dentistry regarding 4% articaine causing paresthesia.
So if somebody says there's paresthesias, this is what they're saying.
This is what they're saying. And there is a Danish thing that came out. They call it the Danish effect. And there was basically the board board of dentistry there said basically that they should not be using articaine for blocks. And this was a long time ago, back in, I think, the 90s. And really what happened is that they jumped the gun on this. They made a mistake. And the European Union did a big study on it. Germany was big involved in this, and they showed that there is no risk to the patient for giving an articaine block. Listen, guys, the chances of you causing a paresthesia by giving an articaine injection in the United States today is 1 in 4.1 million.
Oh, man.
The chances of being struck by lightning, John, is 1 in 750,000.
Oh, nice.
The chances of having anaphylaxis to penicillin, the number one drug that we prescribe for abscesses, is 1 in 50,000. John, are you going to stop using PenVK?
Right.
Because the people that cite this don't know the science. They don't know the reports. They don't know that, hey, look, 92% of these involve mechanical. Most of the time, it's because of the surgical procedures that are done.
So what we need to
anesthesia.
conclude on this is that, articaine is perfectly safe. Now, and the risks that we talk about, we have to really understand the risk is so incredibly low, and that most of the time it's just that you injured the nerve through mechanical means. So I think that, if this hasn't convinced you, send us a message. Let's talk more about it. If you want to see some of this research, let's, give us a shout out on that. We should quickly move into a couple of products that we want to talk about that maybe could make a big difference. We mentioned topicals at the beginning, and the topical that Wes and I use, which is one of our products of the week this week, is Cetacane. Cetacane with a C, C-E-T-A cane, and it is a mixture of 3 different topical anesthetics. We don't have a whole lot of time to go into it, but just to say that it is very effective because it's a mixture of different materials. It has got a little quicker onset and a little bit more of an effect than what you get from just benzocaine. It has benzocaine in it, but it has tetracaine as well, and so this mixture. Yeah, and this mixture just works amazing in my hands and Wes's as well in a very short period of time. Wes we were talking about before the show. Wes, sometimes they use it even for scaling and root planing in the place of Orachix. That's actually where I heard about it first, was somebody talking about before Orachix was even available, was even for periodontal anesthesia. And you can get this in a spray form. You can get it in a gel form.
Liquid form.
Liquid form, yeah. So I would say if you're wanting a better topical, it's worth giving Cetacane a shot. And
hey,
you get
listen,
it from
the dispenser is amazing on this thing.
It is cool. The little squeeze bottle you're talking about.
There's no uncapping of anything and dipping. It really does work well. So
yeah,
I love
so
the
check Cetacane out. And then there was another product, Wes, that you use that I really hadn't seen until you told me about it.
Right. So I have been using this product since residency. In residency, we had anesthetic warmers. And I'm like, And some people used them, some people don't. One of my attendings was more up on them, and he was like, hey, yeah, you need to start warming your anesthetic. And I was like, well, some people use the hot water technique. And he was like, don't worry about that. He said, just get the anesthetic warmers. They're not expensive. They use a little light bulb in there. And one would say, well, Wes, exposing your anesthetic to light will decrease. Well, how much anesthetic are you using, guys? You're going through it like gangbusters. And so
you use your warmer on every
single patient. So here's the thing is that I have 2 of these anesthetic warmers that you can see on the screen right here. And one of them has Citinest in it and mepivacaine. And that's got the black and the tan band in it. So you know exactly what's coming out. Okay. And then I have another one with Septicaine in it, or Articaine. And so that way that I'm always giving a anesthetic that is more closer to that of body temperature. So you can imagine the body's temperature is 98.6, and if you put 70 or 72 degree anesthetic in a patient, part of the reason that they feel pain is because of the coldness of the anesthetic. It's a shock. And so this technique has really taken my injections to the next level. Something I've done for over almost 15 years now, and I will say,
who makes it?
Premier makes one.
Okay. Okay.
I don't know if it's the one, but Premier makes a cartridge warmer. It's 110 volts with a 3-watt bulb. I think I'm looking at it here on one of the suppliers. It's like $68.
Okay.
And I've replaced the bulbs in mine. I've never actually replaced the actual holder. We bought the bulbs off of Amazon or Lowe's whenever they blow out. But I tell you what, it is a huge difference when you give somebody anesthetic that is warm versus, listen, John, I know you do. Use the lip shake technique as a distraction. Yep. Some people, we put the little vibration tool on the actual harpoon. I do none of that. I take and wipe the tissue with a gauze. I apply the Ceticaine topical, rub it into the dried area. I look for the vessels, and I take the bevel of the needle, and my carpal anesthetic gets loaded right out of the warmer into the harpoon, okay? As soon as I remove the topical out of the mouth, there's a hot carpal anesthetic coming right to my hand. Yep. And I put the bevel of the needle right in between the vessels, and I use loops. I use magnification for my injections, and the patients feel nothing. They're blown away. And there's nothing. Listen, if you want to see me give this technique, listen, leave us a comment.
Yeah, if you want to know more about this, we can definitely show you what we do. So this has been a great episode because I think what we got from this was, first of all, some myth busting, some things that, next time you hear somebody make a comment about, well, what anesthetic are you using? Because I'm having trouble blocking people. You can say, well, here's some things that hopefully we can learn that it's not the stuff, some of the stuff we used to think it was that was causing problems. And hopefully you can take that right to your practice and change some things you're doing. It doesn't involve any kind of a crazy expensive things you need to buy. It's just knowing a little bit more about the research and knowing how to apply it. If this show is useful to you, or if our show in general has been giving you some things that have changed your practice, then we'd love to hear from you. Give us some feedback. Give us a message, as Wes said, on Facebook. Let us know what you want to see more of. Let us know if you want to see more about anesthetic technique, or if there are other shows you want to see more about. If there are questions you have, if you want to see more about research, if you want to, send us some stuff telling us why we're wrong and we're idiots, we love that too. Bring it on. We want to talk more with you. We want you to give us a review on Apple Podcasts so that we can get our word out to other people. If they search for dental podcasts, we want ours to come up. And we also want to make sure that if you haven't already, you might, time may be running out here, but grab a ticket to the Voices of Dentistry event. Don't miss that. Make sure we get to connect with you in person out in Scottsdale, Arizona, coming up in just a short while after this will be released. Wes, it's been a great episode. Once again, bringing the pain.
Listen,
this was a good one
to go get a sandwich.
Yeah, I'm ready for a turkey sandwich, man. I'm ready right now. It's always great to get to come to you guys this time of year. We hope you guys have having a great time with your family, getting some good family time. Make sure you treasure that time with friends and family because you never know what tomorrow's going to bring. We thank you for spending your time with us, hopefully on this Turkey Day. And so for Wes and John, we hope you have a happy Thanksgiving. We are the Dental Guys.